So first of all, thank you very much for this kind invitation. It's such an honor for me to participate in this great conference. And I have such a big challenge today that is answered three difficult questions that is regarding therapeutic drug monitoring, TDM, in IBD. What, when, and how? So what's therapeutic drug monitoring in IBD in the context of IBD? It's the monitoring of drug concentrations of biologics and anti-drug antibodies. And we can perform this strategy either reactively, depending on symptoms, or proactively, irrespective of symptoms. But it's really important to emphasize that our difference between the pharmacokinetics of IV and subcutaneous biologics. For IV biologics such as infliximab, after the induction period, we need to measure in the trough level, that is the lowest drug concentration immediately before the next infusion, in the same day or in the day before. But for subcutaneous biologics, this really doesn't matter because after the induction period, we have a kind of steady state of the drug levels and we can measure it anytime between two infusions. But what's the rationale for TDM testing? First of all, there are some pharmacokinetics covariates explaining inter-individual variability. For instance, patients with high inflammatory burden, patients with high CRP, with high levels of circulating TNF, and with low albumin, there is a surrogate marker of intestinal leak. We have increased drug clearance. So usually those patients need more drug. And also the pharmacokinetics is really influenced by the presence of antibodies, that is the immunogenicity. The antibodies increase drug clearance and we can act adding immunomodulators. Secondly, we know that there's a loss of response in the anti-TNF treated patients. The PAINTS study have demonstrated that in Crohn's disease naive patients, treatment with adalimumab and infliximab is we are expected to see a secondary loss of response over time, around 35% after 1 year of treatment. And we know that the pharmacokinetics is strictly related to this secondary loss of response. In this study, in multivariate analysis, drug concentration at week 14 was the major independent risk factor associated with time to immunogenicity. So patients in the lower interquartiles of drug concentrations at week 14 following induction period had a reduced time to immunogenicity. So the induction phase is really crucial. It's really when we have to act proactively in those patients. In addition, it has been clearly demonstrated for all biologics, including ustekinumab and vedolizumab, an exposure-response relationship with high drug levels associated with improved outcomes. And as more ambitious are those outcomes, so if we are aiming to mucosal healing, histological healing, closure of fistulas, we need higher drug levels. So when should we perform TDM? We could perform reactively, that is in the context of loss of response. So when patient is responding to a treatment and then start to experience symptoms. In this case, the TDM will find out which is the cause of the secondary loss of response. If this is a pharmacokinetic failure, if there is immunogenicity, if there's mechanistic failure, and it will guide decision-making. It has been demonstrated that this strategy is cost-effective. When we have the possibility to check on drug levels and antibodies, we have 4 situations. More than 50% of times, we will have subtherapeutic trough levels and undetectable antibodies. This is non-immunomediated pharmacokinetic failure. In this case, we should optimize our treatment. And this is the base to empiric dose escalation when we don't have TDM, because at least in half of the case, we will be doing the right thing. But if you have subtherapeutic trough levels with detectable antibodies, this is immune-mediated pharmacokinetic failure. It occurs in 20% of the case. In this case, we cannot optimize our treatment because antibodies will neutralize the drug. So we need to switch in class. So if a patient was receiving anti-TNF responding to this treatment, we should switch to another anti-TNF, adding immunomodulators. But if you have therapeutic trough levels, it really doesn't mind if we have detectable or undetectable antibodies, because this is mechanistic failure. Even with therapeutic drug level, the patient is not responding to that mechanism. So in that case, we should switch out of class and in the presence of antibodies, add immunomodulators to the second treatment. The landmark Danish Stenhold trial from 2014 has demonstrated that in the presence of loss of response to anti-TNF treatment, when patients are allocated to a TDM-guided strategy or to empirically dose escalation, it was not detected a clinically statistical difference in the proportions of clinical response. But we should emphasize that in 2014, we didn't have other options, other biologics to offer to these patients. We just stopped when the treatment was not effective. But the TDM-guided strategy was shown to be cost-effective, resulted in a cost reduction. The second situation when we can use TDM is proactively. So in patients with stable response, we check the levels, and when we detect that the level is below the target, we optimize early on before patients experience loss of response. The two landmark randomized controlled trials, named the TAXIT and the TAILORx trial, failed in achieve their primary outcomes, but it doesn't mean that they are negative. For instance, the proactive TAXIT trial, in my opinion, is a positive trial, just like REACT trial. In this trial, patients had two phases, the optimization phase and the maintenance phase. And in the optimization phase, patients had their treatment or escalated or de-escalated to achieve a range of infliximab between 3 and 7 nanograms per milliliters. And it was demonstrated that dose escalation led to better clinical and biochemical response in Crohn's disease patients, and dose de-escalation didn't affect disease activity and caused a cost reduction by 28%. In the maintenance phase, the primary outcome was not achieved. That was a combined clinical and biochemical remission 1 year after optimization, but patients in the concentration-based arm experienced a lower proportion of requirement of rescue therapy and stayed in infliximab target range, and patients in the clinically based dosing were at risk for undetectable trough concentrations. The second randomized controlled trial is the TAILORx trial. The major drawback of this trial, which compared two strategies of proactive TDM against the usual care, is that elevated CDEI was really needed for optimization. Just elevated of biomarkers was not enough. And in the TDM arm, 53% of dose escalation was avoided, but no clear how many patients had only elevated CRP, fecal calprotectin. And in the usual care arm, CRP and fecal calprotectin in 60% of patients was normal. in patients who were dose escalated. So it was really hard to show a difference among groups. The groups were really similar. But on the other hand, observational retrospective trials are really optimistic regarding proactive TDM, as the example of this observational trial from Portugal, where patients were undergoing to a proactive TDM strategy aiming a target between 5 and 10 micrograms per milliliters. And it was demonstrated that the TDM arm, in the TDM arms, patients had more mucosal healing, less surgery, and less hospitalization. And the difference in the treatment discontinuation was not statistically significant. Moreover, the group from Boston has demonstrated that for both Crohn's disease and UC, the proactive TDM arm experienced a lower rate of treatment failure over time when compared with a reactive TDM arm. And for adalimumab, what is the evidence? We have indirect evidence showing benefit of proactive TDM for adalimumab from the SERENE UC trial. In the maintenance phase of the SERENE UC trial, patients were randomized to either receive 40 milligrams every week of adalimumab or every other week of adalimumab, and there was a TDM exploratory arm. And we can clearly see that the rates of clinical remission in the TDM exploratory arm is really similar to the arm that received 40 milligrams every week. In addition, patients in the TDM exploratory arm had drug levels very similar to those patients who were receiving adalimumab every week. So you don't need to treat every patient with optimized dose, just those patients who really need it. And it was also demonstrated an exposure-response relationship with increased drug levels associated with better outcomes. So ideally, how should we perform TDM in clinical practice? In my opinion, reactive therapeutic drug monitoring is the bare minimum we should offer to our patients. But I do believe in the proactive strategies combining biomarkers and TDM. This is the proposed algorithm from the Leuven group, where they propose we should proactively monitor the pharmacodynamics using fecal calprotectin and the TDM, the pharmacokinetic monitoring. And in the case patients present elevated fecal calprotectin, we should proactively dose drug concentrations and antibodies and treat according to the algorithm. So in my practice, ideally, I'm not able to do this in 100% of my patients due to reimbursement problems, issues, but ideally for new biologic patients, for anti-TNF, I usually check adequate dose concentrations, aiming a concentration over 10 to 15. And I routinely perform fecal calprotectin every 3 to 4 months, which is supported by the CALM trial. And I dose escalated guided by TDM for anti-TNFs for all patients on any biologics with elevated fecal calprotectin. And after the first year, we should aim for clinical and endoscopic remission. And after those targets are achieved, we should follow all patients with fecal calprotectin every 6 to 12 months and TDM every 12 months, especially for anti-TNFs, and consider dose escalation in the presence of super therapeutic levels. So those are my take-home messages. In 2021, reactive TDM is the basic minimum standard of care for all IBD patients on anti-TNFs. And proactive fecal calprotectin TDM has been shown to be beneficial for improving outcomes for IBD patients on anti-TNFs. And we should identify patients with higher risk of increased clearance, with high inflammatory burden, and with immunogenicity. And this is crucial to our personalized approach. Thank you very much.